think we're going to go ahead and get started. I appreciate that there's some of you who will still be joining. We had a wonderful turnout, over 500 registrants for today's webinar. My name is Dr. David Caro. I'm a physician scientist and also president of Human Longevity. I know many of you personally who are on the webinar today. Thank you for joining. Thank you for supporting us. I have a proud introduction here of Dr. Bob Niculescu, who, like me, is also a physician scientist, MD, PhD. He's an internationally renowned, award-winning psychiatrist, scientist, educator, and entrepreneur. Over the last 2 decades, he has pioneered the field of precision psychiatry in general and the development of blood tests for psychiatric disorders in particular. He is a winner, among other accolades, of the Theodore Reich Award from the International Society for Psychiatric Genetics in 2007, the National Institutes of Health Directors New Innovator Award in 2010, and the Indiana University Trustees Teaching Award more recently. He founded MindX Sciences as an entrepreneur to help transform mental health. He has dedicated his career to the improved understanding, treatment, and prevention of mental health issues, and has personally treated over 10,000 patients. So with that introduction, I will leave it to you, Bob, to lead us through a presentation about 30 or 40 minutes, and then we'll leave ample time, folks, for Q&A.
Great. Good to be with you all. Thank you very much, David, and thank you to Wei Wu for inviting me. I'm a big believer in what Human Longevity is trying to do. The topic today is how mental health overlaps with longevity, and what could we do to better sort of prepare us to live 100+ years, as those who work with Human Longevity are aiming for. So what I'll present today comes out of hardcore research, but there are also practical applications that we've developed at MindX Sciences, and I will sort of go through things in a hopefully not very painful way. All right, so as mentioned, I come from academia like David, and like David, we saw the need to translate this to practice, and that's why we started MindX Sciences a few years ago. This is one of my favorite quotes. It's from Frank Lloyd Wright: "The longer I live, the more beautiful life becomes." We live in very interesting times where all these scientific advances can now converge into helping people live healthier, longer lives, and with this whole acceleration that's occurring now with AI and so on, is sort of one of the most interesting times to be alive, if not the most interesting time in the history of mankind. So let's all be healthy and be around for it. So mental health, as all of us know, is a big problem. It's a very common one, and it shouldn't be something that's associated with stigma or with all this uncertainty that's going on right now with it, but it is. And I'll present some of the solutions that we brought forward to help alleviate that. So 1 in 5 people will have a clinical mental health episode in their lifetime. And most individuals are not treated, diagnosed properly from the beginning, treated properly, and so on. It's also very disruptive and very expensive and sometimes tragic to let things progress to a full-blown clinical episode. Some of them end up with suicides and so on. So it's much better to identify early on risk factors, identify early on things that are not optimal, and optimize them and prevent. And that's what we're strong believers in. So the big advance that we've developed at MindX Sciences, first in my academic research groups and then over at MindX Sciences, is we currently have blood tests that can be done to assess your mental health. And these blood tests are a first step in helping a doctor figure out in an objective way what, if anything, is going on. with your mental health. It took us, 2 decades to develop these tests. It's very hard to do this type of work, unlike in cancer or other things, where you might have gotten blood tests or liquid biopsies to look at risk factors and so on. In mental health, we can't biopsy our target organ, the brain, as part of the R&D. So we had to take a very elaborate, careful approach to find peripheral markers that track symptoms, that track disease severity, response to treatment, and so on. So they help with this first step, assessment, diagnosis. They also help with the second step, which is what medication should you be on. So these markers can match people to the right, to medications that match their biology, and also to nutraceuticals that match their biology. And this is all, science-based, empirical. We've done a lot of work on it. There are algorithms that are used to analyze your RNA data to provide these inputs. And then the third step is that should be part of this workflow is what dose of medication should you be on? And we don't do that. There are many DNA tests on the market that do that, that look at whether you're a fast or slow metabolizer. And based on that, your doctor can start you at a low dose or a higher dose. Or they can just, do it empirically, start you on a low dose and go up if need be. So, and as I mentioned, cancer has been working on this for many years. In fact, my research career started in cancer molecular genetics at Scripps in La Jolla. And when I moved over to brain research and brain health, and when I went over at UCSD to complete my clinical trainings in psychiatry and so on, I brought a lot of that mentality, technology, and so on in mental health, having this sort of goal and ambition to bring mental health and psychiatry on par with other medical specialties, in this case, specifically with cancer. So it took us 2 decades, but we've closed the gap, and currently, we're able to offer similar testing to what's occurring in cancer. So about 4 years ago, I put together a company to help bring this to doctors and patients. Before that, whenever we made a discovery and so on, patients, families, and so on would inundate me with calls, emails. They would want to come and get tested, and I would tell them, look, this was all done in a research setting. You can't just come to my academic lab or to the hospital and get tested. And finally, 4 years ago, we decided to bring this to clinicians and patients and for Mindex Sciences. Put together a team of very experienced people who've done this before in other settings. Some of them might be on the call. And we have a website, Mindex Sciences. You can come there and see who we are, what we do, and so on. And here at a glance is the blood testing report that we provide. And I just wanted to highlight a couple of things over here. So we call these, the brand is Mindex One blood tests. And we chose one because in a single place, you have objective information about assessment and treatment. So diagnosis and treatment information in a single place. Now, we don't make the diagnosis. We don't treat the patients. We just provide objective information to doctors, just like other lab tests, so that they can use their clinical judgment, other information, other tests to arrive at the correct diagnosis and then to guide their treatment. But it's a big difference when you fly with instruments as opposed to flying blind. That in psychiatry to this day, a lot of clinicians just rely on talking to patients and their impression on what the patient is sharing with them and so on, and that's suboptimal. So currently we have 7 tests on the market for mood disorders, for anxiety, for stress, for pain, for suicidality risk, for memory disorders, and for longevity, which I'll spend more time on. We're going to launch in the next month or so a test for psychosis, for schizophrenia risk, and later this year, after we go through all of our processes of R&D and publish, we will launch a test for attention, for ADHD, which has become a big issue currently. So what about mental health and longevity? This is a funny quote, but there's some subtext here, which is that your mind has profound influence on not just the quality but the quantity of your life, we think. And here's some of our thought process and some of the evidence for that. So most people tend to focus, and most researchers and most clinicians tend to focus on passive mechanisms of aging and passive mechanisms of longevity. And what do I mean by that? So passive aging is the usual wear and tear, right, that we all experience in life. And then active aging is less appreciated. It's something that we are proponents of. We have some evidence for, which is that there's an actual shutdown of your biological machinery that occurs if you are despondent, depressed, all the way to suicidality. So that's for aging. Conversely, for longevity, we tend to think, longevity as a passive process where you avoid damage, you have, you won the genetic lottery, you have resilient repair mechanisms, detoxification mechanisms, and so on. But we think that there's also an active longevity going on where the cellular machinery involved in rebuilding, rejuvenation, and so on is turned on when people are optimistic, when they have a strong purpose for living. So the active part is something that is more novel and where I think a lot of progress can be made. And the active part comes from this, serendipitous discovery that we made that there, we were looking for gene expression changes associated with mood disorders, with stress, and we found a subset of genes that were changed. They were the same genes, but changing expression in opposite direction in longevity versus suicidality, which are opposite sides of the coin, both of and we call this the life switch. So this sort of unexpected discovery from two different lines of work that we were doing. We did a lot of work on understanding suicidality, and we were doing some novel work on longevity, and we found that we converged on the same set of genes that were changed but in opposite direction in the two where we thought were very different biological phenomena. So we call this the life switch. And this is the initial seminal work was published a few years ago. It was a collaboration with colleagues at Scripps. It was a very elaborate study. I'll show you a few slides from that work, just to not to try to impress you, but to impress upon you that there's a lot of science and actual data that went into this. And I have a friend who likes to say that when you make extraordinary claims, you need extraordinary proof. So the fact that we were converging on this mechanism of active longevity, we wanted to make sure that, first of all, for ourselves, that we got it right, and then, before publishing it, proposing it to the world. And so this is a very large study. We did separate studies first in worms and in humans. In worms are used a lot for longevity because they have a short lifespan. You can test all sorts of medications and drugs on them, see what works. You can modify their genes and see how they respond to that, and so on. It would take decades to conduct longevity studies on humans, right? So we did a screen in worms where we ran thousands of compounds to find things that prolong life. This is work in collaboration with Professor Michael Petroshek at Scripps. And turned out that the top hit was an antidepressant, mianserin, which is used a lot in Europe, less so in the US. It's not on the market in the US, but has a similar cousins over here. So that was very intriguing that, the top hit for longevity was an antidepressant, something that regulates mood and stress. And separately, we did some human genetic studies called GWAS, genome-wide association studies, to see what in adults who are aging, what mutations in your genome are associated with having more depressive symptoms versus not having them. And then we converged the data sets, and we found a series of genes that were modulated by these, by meancerin, and were also involved in this genetic mechanisms of depression as we age. And we did some additional work to look at converging evidence for involving those genes in mood, stress, longevity, and we scored them for amount of evidence. The top gene turned out to be a gene called ANK3, which was previously unknown to be involved in these things. Once we had these findings, we wanted to reassure ourselves that it's the culprit. So we went back in worms and altered this gene to see if that blocks the response to meancerin, to the antidepressant. If ANK3 is involved in that longevity response, if you delete it, then the longevity response should not occur. We also looked in human samples, both gene expression and genetic studies, to try to understand whether it's associated with the biology of longevity and with other things related to mood and stress. So this is, don't panic when you see this. I just wanted to show that we did a lot of work looking at different mutants of this gene in worms, and the take-home message is that meancerin only works, has a strong effect in prolonging life if this gene is not mutated, if it's wild type. Otherwise, if you mutate it in a worm, it decreases significantly the effect of meancerin prolonging life. But we're not worms, so let's see what it does in humans. So we looked at levels of this gene. This gene is decreased in expression in younger people, and then as we age, it tends to increase in expression. This is work in blood. And then later on, it sort of decreases again a little bit. We think this is sort of a selection effect. Most people who had lower level of this gene have, by that point, died from diseases and so on, and the remaining population is resilient. So lower levels of this gene are associated with youthfulness, and higher levels are associated with age. And we looked at mutations in these genes, these letters in the DNA that are associated with longevity or not. And there are specific SNPs, specific letters that increase your odds of living longer by 40%, 50%. And, that's remarkable, because in genetics, a lot of the polygenic risk scores, where we put thousands of these letters together to try to predict something from your DNA, have odds ratio of maybe 1.05, so increase your likelihood by 5%, maybe 10% on a good day. Here, just this mutation, this SNP, increases it by 40%. So it seems to be very powerful, at least in terms of looking at this effect of aging. It seems to be to do so more in males, less of an effect in females in this case, but this is like one of the rare examples where males are faring better. Overall, in all of our research, including, I'll show some data on longevity, it's the females who, as you know, live longer, are healthier, deal better with mental health issues and so on. So this is at the genetic level. So I know that at Human Longevity, there's a lot of sequencing going on and so on. So perhaps in the future, upon future, looking at this, it could be something that could be looked at your DNA, not just at gene expression level, as we do at MindX. So here's that surprising discovery. We looked at these sort of top genes that were associated with longevity, modulated by mood and stress, and these 22 of these top genes were flipped in opposite direction in suicidality. So for example, ANK3, which is the top scoring gene, is decreased in longevity in the ondansetron treatment. It's increased in suicidality, and so on. There's a whole series of them. The second one also is very interesting. It's superoxide dismutase involved in quenching free radicals in the body. So once you have this type of data, you can try to find pragmatic insight. So these genes, some of them have evidence for being modulated by omega-3s, by fish oil. So if you don't remember anything from this call, take your fish oil supplements if you don't have counterindications to that, like bleeding disorders. You also can use this whole signature of drugs of genes, this panel of 22 biomarkers that we think are involved in active longevity, to see, what other drugs modulate this signature in a positive way in the direction of longevity. So these are the top hits here. I'll walk you through them. It's a busy slide, but number one on the list is sort of a compound used in cancer. It's more difficult to use in routine practice. But number two is estradiol, estrogen, basically. So that might be one of the reasons why women live longer than men, and might be something to consider in discussions with your doctor, whether postmenopausal and women, there's reason for not. What are the pros and cons for supplementing with estrogen? It's a complex decision. Fourth on the list was nutraceuticals, apigenin, that's an antioxidant. Then you have trolitazone, and in fact, a number of anti-diabetic medications here on the list: trolitazone, rosylitazone, glibenclamide. So it's very interesting, this connection between sort of diabetes and aging and longevity. There are some other nutraceuticals that we consider. Resveratrol was on the list, luteolin, acacitin, and last but not least, folic acid, which is something you can, get in the vitamin section of your, Whole Foods or Trader Joe or CVS or whatever. So again, using these signatures, we can match people to, to practical, applications and medications that they could consider along with their clinician for modulating this life switch in the right direction. We've also looked more broadly, since we've done over a decade of work on suicide risk biomarkers. What other compounds normalize those biomarkers that might also be helpful in longevity? So here you want to find the complete opposite of the signature, right? So, fluoxetine, which is Prozac, was good at 0.8, so 80% normalization. Clozapine, which is another drug which is known to influence suicidality. But look at what was the almost sort of like perfect opposite to the broader suicide signature. Metformin and chlorogenic acid. Metformin, again, it's an anti-diabetic medication, so it fits that diabetes theme that we were identifying there. And those of you who know what chlorogenic acid is, I think David should give you a Starbucks gift card, because it's a compound present in coffee. All right, so a couple of things about metformin. Some of you might know that it's being tried now in clinical trials for longevity. It's an old medication for diabetes that has very interesting evidence for helping not just diabetes, but longevity, maybe preventing some cancers and so on. I won't go into all the science behind it, but suffice to say that it's probably the most innocuous and promising of the longevity compounds being tried right now. There are others like rapamycin and so on that are a bit more delicate to use. And then chlorogenic acid, which was the strongest there. It's a compound present in coffee. So, Starbucks may be doing a lot more for suicide prevention and longevity than they know. Stronger than Prozac and other things. It's a polyphenol that's present there. Once you start digging, there's evidence about protective effects in neuron against neurotoxicity and so on. Here's an example of a study done on that. So a lot of science behind those things once you start looking. We didn't find kale on the list. I'm not sure if that's something that you eat. I hate it, but if your doctor recommends it, might be something to consider. It's not. We don't have any empirical evidence for it, thank God, and we do have a lot of evidence for chlorogenic acid, and I drink a lot of coffee. All right. So we and others think that aging is a treatable condition. Hopefully this is just sort of an exuberant elderly, not a suicidal one. It's it's something that we'll all benefit from. I think that we're reaching that point where the science, the medical advances, the practical applications are converging for people who are early adopters to start benefiting from some of these things. So the sort of preliminary conclusion would be that mental health does influence longevity, not just indirectly that, when you're depressed or anxious or stressed out, you're not taking care of yourself, you make poor lifestyle choices, diet choices, you're not taking your medications for other things, but directly at the level of the biology. And, we used to say that there's no health without mental health. I think now we can start considering that there is no longevity without mental health. So coming back to what is currently available from Mindex Sciences, we have these tests for 7 indications. They are self-pay currently. There are CPT codes for them. We're hope over the next year or two to get some of the insurance companies and so on to see the value proposition of using them. These tests are expensive, as a lot of genomic tests are, but they are less expensive than a day of hospitalization. So we're trying to make that clear to insurers. But for now, they're self-paid. They have decent sensitivity, specificity, accuracy comparable to other things in medicine. And this is data from independent cohorts. We're big believers into sort of doing things properly, looking at reproducibility, predictability, and so on, not just relying on p-values and statistics. This is how a mood report would look like. And again, we call it mood report. We don't call it depression or bipolar because we're not making the diagnosis. We're providing objective information about mood to you and your doctor, and that can be used to, along with other clinical information and other tests to arrive at the proper diagnosis. But for low mood, for example, for low mood is depression, basically. You can, this is an actual de-identified patient report. You get some scores for your state and then future risk for depression, future risk for mania. If you're lighting up on both sides, depression and mania, it's likely you are bipolar. You have what we call bipolar disorder, where you go from low moods to high moods and so on. It's a very common disorder. It's often underdiagnosed, misdiagnosed. People get put on antidepressants and they don't do well. This patient was thought to have depression, but our test showed that she had bipolar. Her top match was a mood stabilizer. Her doctor started her on it and she did great. So you can see here on the right-hand side, we have the medications. On the left-hand side, the matched nutraceuticals. And, pick your favorite. They're ranked by matching to biology. Again, we don't know anything about the patient. So, there could be allergies, counterindications, drug interactions. Your doctor looks at this and she or he decide what to use, if at all. But, these tests do provide that sort of objectivity that's been lacking until now in mental health. We also provide integrated reports, like if you have got tested on various panels for stress, suicidality, anxiety, low mood, etc. Your doctor gets an integrated report along with what the best medications and nutraceuticals overall are, given the multiple things that are going on. And that's the reality of it. I mean, most people have multiple things going on and, finding a best match for this and then a best match for that and so on. And, it's hard for a doctor to integrate and prioritize things. So we do this all empirically, given their biomarkers for different mental health domains, what is the best choice to hit all those multiple things. So these tests can be used when there's some concern, you have some symptoms, you're not feeling well, etc. Your doctor can order them as a send-out test like you would do for cancer, and doctor gets the results a few weeks later, calls you for a follow-up, integrates the information in your treatment plan. They can also be used to monitor response to treatment. You got started on something, see if you're responding well, and so on. And ideally, in the future, they'll be used for prevention. They should be part of your annual exam, just like you do at Human Longevity, where you get, the works done once a year or twice a year, and you can catch early on if there are any abnormalities and nip them in the bud. We have a companion app that goes with this test. The app, like the test, came out of 2 decades of research, so we didn't just have an app, so we have an app. There are 10,000 apps out there. This one is all science and research based, tested against clinical questionnaires, tested in clinical settings. Again, so you can have numbers, so you can track your mood, your anxiety, your stress, your pain, different aspects of your life at home, privately on the app. We don't collect the data, it's all on the app. So you have numbers, it's like a Fitbit for the mind or an Apple Watch for the mind. So when you go to your doctor's appointment, or you can email them a copy of the report, they can see, how you have been doing in between appointments. Very useful. I use it with my patients all the time. We've developed a Good Life Score, very simple 7 items that integrates the 7 best things you could do to prolong your life, basically for your active longevity. And, these things are not a secret. All of us know what the correct things to do are, but having them as a checklist daily, where you see, did you eat your Mediterranean diet, or something similarly healthy? Did you get your 10,000 steps? Did you get 7 hours of sleep? Did you socialize? Were you intimate? All these, the 7 things that have the most empirical evidence for making a big difference in your longevity. Having that as a daily checklist is very useful, so you can keep track of it, you get your daily score, and so on. All this data, as you collect it, you can start integrating it, the data from the app with the data from the blood test, and looking over time how things evolve and so on. In the future, we'll have a Mindex AI that can help people with their personal decision, can help their doctors. We've started work on that. We're training it on our data sets and so on. So you can look at, your life success, your life satisfactions. These are very important because they determine whether your mood and stress and outlook on life is in the right direction or not. And that, as we were discussing before, can profoundly influence your biology and your active longevity. So we actually compute an active longevity score just based on how you feel, think, and behave. We haven't integrated the blood work into this yet, because everything in the app, we keep it confidential, so we don't get that data yet to integrate it with your blood work. But very useful. You keep track of these things, and you see, I'm on the plus side of things. I'm moving in the right direction, or God forbid, you're having a negative score on active longevity, meaning there's some things you need to identify. We can help you with that and address in your life, so you're, flipping the switch in the correct direction. So we think we're doing our bit to help healthcare move into the 21st and hopefully in the future 22nd century. We think that mental health care is part of should be part of routine healthcare, and products are already here. Early adopters, doctors, patients are using them. I like this quote from William Gibson, my favorite science fiction writer, that says, "The future is already here. It's just not evenly distributed." Early adopters like you have seen that Human Longevity, the similar places. We're doing our bit for mental health at Mindex Sciences. And again, what we've put together from molecular to digital products can be used not only for acute treatment when people are not doing well, but we need to move more and more in the direction of prevention. The future of healthcare is prevention. So thank you very much, and happy to take questions from the audience.
Thank you, Bob. So folks, I already see a bunch of questions piling up. I'm going to sort of sift through, and I don't think we'll be able to get to everyone's question, but I'm going to try and grab some of the repeats. I've already seen a few. So please, if you have some questions that you'd like Bob to weigh in on, please enter it in the Q&A and the chat. But I'm going to start with one that's already come up, Bob. You know, we have in common that we're all about, as a company, as a medical group, treating the root cause of disease. And, so much of sick care, whether it's for psychiatric disease or, neurodegenerative disease or dementia or cardiovascular disease, we often, as a sick care, healthcare system, sick care-based healthcare system, we treat symptoms. So rather than understanding the root cause of high cholesterol, we treat with a statin. Rather than going to the root cause of Parkinson's, which is generally mitochondrial dysfunction, we treat with levodopa. And I wonder if you have sort of a similar take when it comes to neuropsychiatric disease, whether, generalized anxiety, bipolar, OCD, just as examples where, we're throwing SSRIs, at folks when, in fact, if you look at the root cause, it may be sort of cellular dysfunction, mitochondrial dysfunction, not enough ATP in the neurons producing dopamine and serotonin. And I'm getting to the sort of comment and question here. It's probably no surprise that actually, metformin is not only a longevity drug, but it also is implicated in a positive sort of neuropsychiatric profile. Because at the end of the day, a lot of disease is insulin resistance. A lot of disease is inflammation. A lot of disease is mitochondrial dysfunction. And why should neuropsychiatric be any different than neurodegenerative, for example? So I'm wondering if it's in your clinical practice as sort of first line to really, when someone presents kind of with a new onset neuropsychiatric disorder, is there an approach that's benefited by going to sort of root cause approaches, whether it's metformin, insulin sensitivity, mitochondrial function, reducing inflammation? I just wonder if you could speak to that. We've got a lot of questions on that.
Yeah. No, I couldn't agree with you more, David. I think you're exactly right. Spot on. So we start with empiricism. So we start with, when we did our work, we started with the whole genome. We didn't have a hypothesis. We didn't want to be biased one way or another. But it's interesting that we converge on things that other people have come across. There's a strong movement now in psychiatry called metabolic psychiatry, where people are looking how certain types of dietary interventions and so on optimize brain function. I think they all work with modulating neuronal excitability. A lot of the effective medications in psychiatry actually work in terms of modulating neuronal overexcitability, which is a common mechanism in when people overreact to stress, to anxiety, to mood problems, and so on. So we wanted to be empirical and not hypothesis driven. We do discovery type science and see, after careful, stepwise approaches, what we end up with. But it's very nice. And, in science, it's great when that happens, where different approaches converge. So if I were to be bold, and why not with this audience, right? We think anxiety is overreactivity, it's excessive signal transduction. And we think mood is levels of cellular energy metabolism, lower levels when you're depressed, higher levels when you have high mood mania. And psychosis and other cognitive processes have to do with connectivity between neurons and so on. So, and the biology of our findings, our biomarker findings, our genetic findings support that. And the medications that turn out as good matches support that. So if that's the case, we should be treating empirically the biology and what people have, as opposed to treating this sort of labels that the current psychiatry, DSM labels. I don't think that these labels are accurate reflections of the territory. They're not a good map of the territory. So, for example, in the app, there's a dimensional screen there that shows, your anxiety dimension, your mood dimension, and your cognitive dimension. 3D, you get measures on those 3 dimensions, and you're at that moment in time, you're a dot, XYZ coordinates, that's you at that moment in time. And you repeat that, over days and weeks, and you get a series of dots. That cloud, that mental landscape cloud, mindscape cloud, is probably a better description of who you are than trying to stick you into one of these boxes: anxiety, depression, and so on. Most of us everybody is multidimensional, and you need to treat the person and what they have biologically. Inflammation, and the second point related to sort of the profound points you are making is that the brain and the body are strongly interconnected. They're all sort of we have the same set of 20,000 plus genes upstairs and downstairs. There's a lot of crosstalk and so on. So you're seeing the same biology influence what's happening below the neck and above the neck: inflammation, metabolism, and so on, which is an opportunity because you can use things that modulate inflammation, metabolism, and so on to address at a very profound biological level mental health disturbances, and basically solve everything with a single unitary approach, as opposed to this sort of excess of using SSRIs or other things. They have side effects that may make people worse, that are, if they're mismatched to what the person actually has, and so on. So, in most other areas of medicine, we understand mechanistically what's happening, and that's how we treat people. In psychiatry, we've been symptomatic and just sort of found things that may modulate symptoms a little bit, and then they got approved and marketed. And I think we're moving beyond that era with some of the work that we're all doing together.
Great. I have a similar question here on inflammation, and it comes with a little background. Treating inflammation is certainly a big part of what we do at Human Longevity. And I think, to your point, when you show the app, we all kind of know sort of almost common sense, what are the, modifiable risk factors and levers that we should be pulling. But I think the key question for our clients, and that we as physicians try and answer, is, well, which lever should I focus on? And some people would comment, well, you can't convince people to change if they're not going to adopt these, lifestyle regimens. There's not much you can do. And I actually really push back on that, because I think in our experience, we find that there actually might be one of these levers of dysfunction that people aren't even aware of. For example, gut inflammation. This is going to get to the question. If you've got gut inflammation, if you've got nausea, you might have sort of a neuropsychiatric disturbance. And, it's probably going to prevent you mood-wise, energy-wise, from actually doing physical activity or being intimate or going out and being social. And so just being able to identify gut inflammation, whether it's through calpectin or understanding food allergies through IgG or IgE, or at least using those tests to get people to do an elimination diet, eliminate grains, eliminate dairy, eliminate nuts, and actually see what is causing nausea. If something's causing you nausea, it's a very good high likelihood that it's leading to some level of inflammation, which we know is not good. So this kind of gets to my sort of question. We have a lot of folks that come to us concerned for neurodegenerative disease, including Parkinson's. And we have seen phenomenal results, not surprisingly, since we know that probably the Parkinson's pathology starts in the gut and goes to the brain. So not surprisingly, reducing gut inflammation has had such positive, profound implications, in some cases, reversal of movement disorder symptoms in early Parkinson's. But along with that, what we've seen, and we know that there's a form fruste of Parkinson's, sort of neuropsychiatric form fruste in males. It's often someone who's a little bit anxious, a little bit on the OCD, a little bit autism spectrum-y. And our whole view is, these things are not disaggregated, that probably the underlying root cause to both the neuropsychiatric form fruste and the actual later in life Parkinson's is the same root cause, which is probably inflammation, mitochondrial dysfunction. And so when we, are treating someone with prodromal or mild, dementia or Parkinson's disease, we're really altering their gut microbiome and reducing their gut inflammation. We're also seeing positive benefits in terms of mood, in terms of reduction of anxiety. And I'm just wondering if you could comment more sort of thoughtfully on the whole kind of nutrition approach to, neuropsychiatric disease. Including, there's a lot of talk about intermittent fasting, eliminating grains, eliminating gluten. I wonder if you could talk about that.
Yeah, no, I love that area. So again, like great comments, great perspective there, David. And I'll share my, what our data shows and my viewpoint on it. I'll qualify it that way. So first of all, let me address that issue of nutraceuticals versus medications. We put them side by side, not for philosophical reasons, but the evidence, they're all molecules, and the evidence is very strong for some nutraceuticals, on par with medications or sometimes better. In particular, I showed some evidence, omega-3 fatty acids, fish oil capsules, those should be, almost the opt-out option for health in general and for longevity in particular in this case. Unless there's some counterindication, you're allergic to fish or you have a bleeding disorder, you should strongly consider being on those omega-3 fatty acids. And there are other things like that, where the evidence is very strong. And, so it's not that some people prefer not to take medications and prefer nutraceuticals. We just sort of offer the evidence that some nutraceuticals are as strong or stronger in terms of biological effects and evidence than some of the medications. This issue of gut inflammation and brain, it's extremely interesting. I'm a professional skeptic, so for many years I lagged actually behind the field. I wanted to see the evidence. I felt microbiome is too complex, et cetera, but the evidence is very strong, and some of the things that we found actually are related to that, some of these biomarkers and so on. There's no question that inflammation in general is toxic for the body and toxic for the brain, and it has to be dampened, chronic inflammation. But a lot of it starts in the gut, and it's not generally appreciated, but you have a whole brain there in the gut. There's a lot of serotonin, a lot of other neurotransmitters, and so on. And the signaling, the bidirectional signaling that occurs between gut and brain through metabolites, through vagus nerve, through other things, is incredibly complex and a target of opportunity. So big proponent in my patients, of using probiotics. So I'm originally from Eastern Europe. There's a drink there called, I don't know how it's pronounced. Different people have different pronunciations, but kefir or kefir, or, you hear all sorts of things. KEFIR. It's a great probiotic drink. It's available, at Whole Foods, other places. A glass of that in the morning is transformative for a lot of my patients who have IBS or gut dysmotility and so on. And there are other probiotic formulations. So there are things that start to filter out of our scientific and medical insights into things that can be done day to day. In terms of like adopting these lifestyle changes, the doctor can share the information with you, and we know that ourselves when we're on the other side of the receiving end of advice, right? Physicians receive advice for their own healthcare. Unless it's something that's simple, actionable, and that becomes part of your habits, and you have something that you track every day, you might drift and not apply it. So that's why we made the app very simple, and the simple reminders of powerful things. And these checklists and other things that are there are extremely informative. I mean, you might know that those 7 things are good for you, but you don't sort of keep them at the forefront of your mind or compute them daily. But if you take 30 seconds to check on those things there and see what your score is, sort of reinforces that you should you're drifting a little bit, or you're doing great, keep up the good work, which becomes its own sort of positive addiction and so on. Lastly, that issue of Parkinson and other form Frust and prodromal syndromes. Again, it's related to the fact that there's some core biology that is shared across disorders. So for Parkinson per se, those neurons are overexcitable when people are younger, and then they get burned out and die. Those dopaminergic neurons, they start losing them when they're older, and that's sort of the biology of Parkinson there. And so reducing the overexcitability and neuronal excitotoxicity earlier on in life may prevent the development of Parkinson. And chlorogenic acid, speaking of actionable nutraceuticals and so on that I mentioned there, along with metformin. Chlorogenic acid that's present in coffee. I showed there briefly an article, but there, that there's good data that it reduces neurotoxicity in some studies from Japan and so on. So I'm a big proponent of, if you like coffee, drink coffee because it's great for you. It's great for your mood, start your energy, your circadian mechanisms in the morning. It's great now with chlorogenic acid for your brain health. Maybe good for your longevity. Certainly, we have that evidence that it may reduce your suicidal risks and so on. So, I'm not a spokesperson for, coffee manufacturers or Starbucks or so on, but by all means, if you enjoy coffee, go for it all out, because it's very good for you in a variety of ways, including Parkinson's. So there's good epidemiological evidence that coffee drinking protects or slows down the onset of Parkinson.
Hey,
So, yeah.
Hey, Bob, can you, one of our requests was if you can stop sharing, that way they can see our profile rather. Oh, there we go. Good, good. Okay. Well, we've got about 10 minutes left and many more questions. Won't be able to get to everything. So there's a question here, Bob, on, and again, common to our practice. I think in general, there's been a lot of debate over the years of, treating so-called menopause and menopause. At a high level, this question of, is aging caused by low steroid sex hormones like testosterone or estradiol, or does, low estradiol and testosterone cause aging? And I don't know that we know yet, but I will say, based on our experience, we're pretty bullish about, in folks who are low, we're not talking about augmentation, but we're talking about replacement, in folks who are low, either estradiol or testosterone, whether it's injections or gels or testosterone pellets. We find many positive benefits from replacement, mood, movement, libido. And, I think, again, it gets to sort of this root cause, which is, as we age, our biologic age increases along with our chronologic age. We have mitochondrial dysfunction. Our neurons aren't producing as much ATP. And I think probably these steroid sex hormones, is probably, thousands of things they do, but among other things are probably stimulating our mitochondria to remove misfolded proteins, whether it's amyloid or tau or phosphorylated synucleinopathies. So we're fairly bullish about replacing when low. What is your experience in your practice with recommending replacement?
I think it's a very interesting area. It's also a controversial area, so it has to be done carefully. But for example, I showed there that estradiol was one of the top modulators of active longevity. So I don't know if I would go so far as recommending that men take estradiol to prolong, to boost their active longevity mechanisms. But certainly, if you're a woman postmenopausal and there are no strong risk factors for taking estrogen, supplementation is probably, very good for this active longevity angle. Does a lot of other goods in terms of osteoporosis, energy, etc., quality of life. So that's a discussion that needs to be had. All these, this testosterone, estrogen, other steroids are really, neurotrophic type molecules. They keep cells, functioning well. And then when you lose them, the cells function less well and shrink, and you start having, cellular loss, muscle loss, neuronal loss, and so on. They're very powerful drugs, so everything in moderation. Supplementing deficit, there's a good argument for that. Going beyond, what's the normal range, is plus minus. I mean, I've seen a lot of patients go on the other side. Like, it works great for depression to supplement them. That it resolve their depression, but then they overdo it, with other doctors, and then they come manic. I mean. Yep. Yeah, and we've seen that in athletes and so on, like roid rage, steroid-induced mania, etc. So everything in moderation, I think there's a sweet spot for using them. They're very powerful. They work great for mood. And if you don't normalize them, a lot of the other medications actually don't have, a good enough effect. So there's this underlying biology that if it's not addressed, you can give people antidepressants and other things, and they won't work or work as well as if you correct this deficit first. So this, as you know, there's a risk for cancer with some of them, and you know, if you balance your cancer risk with all these other positive effects that they have in terms of energy, longevity, ability to do things, quality of life, and so on, I think in each patient you can arrive at the sort of the right sweet spot for using them. So definitely they should be part of the conversation for everybody who's interested in those things. Just sort of carefully and in moderation.
No, thank you. You know, one comment that I'll just make is, again, this comes from a lot of experience in our clinic. You know, everyone sort of forgets that we men need estradiol and women need testosterone for ideal, you know, cognitive, mood, and libido benefits. And so it turns out when you give anybody, whether male or female, for example, testosterone pellets, you're not only increasing, of course, testosterone, but also estradiol, and you're also increasing, in general, your hematocrit. And as long as you don't do that too dramatically, probably having a high normal hematocrit, more oxygen being delivered to neurons, probably plays a role in the overall benefit. So just a comment. I think everyone, a lot of folks, when we bring up this, they're like, oh, you know, I just want testosterone. I don't want estrogen. And women are like, I don't want any of that testosterone. But we forget we actually need both, just different levels. But I'm gonna, Bob, I've got one last question here, and then we'll close. And you probably knew I was going to ask this one because it's getting so much attention lately. You know, the GLP-1 agonist, Wegovy, Ozempic, and we, you know, in clients who are candidates, we do prescribe. And, you know, it's not just the glucose profile that improves, it's mood. We're seeing, you know, memory improvements. Recent study showed that for folks with early congestive heart failure, there's an improvement there in ejection fraction. I think it's along the lines of sort of the whole metformin story, which is that we're just improving with these powerful drugs, insulin sensitivity. So we're pushing glucose out of the blood into the neurons, into the cardiac myocytes, into the skeletal muscle where the glucose belongs. And at the end of the day, our mitochondria need glucose and oxygen to make ATP, right? So I think we're just seeing, and maybe it's not so surprising that, you know, these GLP-1 agonists are having such myriad effects. What is in your clinical practice, what's been your experience with the GLP-1?
No, it's a very interesting area. So first of all, they work great. They work dramatically. You know, it's a dramatic effect with them. It's a class effect. So all these different sort of compounds that are similar from Novo, from Lilly, from where they work. The challenge is that they're relatively new, so we don't know the long-term side effects. And with any medication, you know, there are like these reports that you get sometimes that suicidality or you know, so anything that modulates appetite has some indirect effects on mood and suicidality. So we have to be careful about that. My opinion, they're a net positive. If somebody, you know, is overweight, has, you know, wants to optimize their weight, their metabolic profile, have those ancillary benefits for cardiovascular health and so on, by all means, they should be taking them, but monitor things carefully in terms of their mood, their any emerging suicidal thoughts and so on, because there are case reports related to that. Metformin has been around for, you know, 50, 60 years. The safety profile and what it does is much better established. It's also, you know, dirt cheap. It's, you know, it's a generic medication and so on. So I steer my patients, given our own data and the data of other people in the field, and a lot of longevity experts and so on take metformin themselves. I steer my patients initially to low dose metformin. If they don't need like a dramatic and fast weight loss, and I'm more comfortable with that conservative approach. There's some data for cancer prevention and other things and so on. It could turn out that, you know, these other newer medication after 10, 20 years follow-up, you know, they're as good or better than metformin and some of the other things. We just don't have the evidence, whereas we do have the evidence for metformin. So that's my take on it, sort of a conservative take, first do no harm and so on. But, you know, they work great. monitor people carefully for any emerging psychiatric side effects. They're not common, but they do occur. I've seen that. And metformin is something that shouldn't be forgotten and should be used, more often. I take low dose metformin based on what I've seen with our data. I know a lot of longevity experts who take metformin, David Sinclair, other people. And so the data for it, the converging data, is very good for metformin. The other compounds are newer, so we don't know.
Great. Well, thank you so much, Bob. It's a real pleasure. I know we've had conversations before, and I look forward to future conversations. Thank you for all who joined our webinar series. And again, thank you, Bob. We're grateful. Take care, everybody.
It's been a pleasure. Thank you very much for your comments and questions, and good to be with you all. Have a nice evening. Bye.
Thank you.